Let's start with giving you an update. So, as you heard so nicely earlier from Ruben, Saga, and the discussions that we had, obviously lots of new issues and excitement in the upfront setting. What I wanted to share with you was updates from ASH that go a little bit beyond that talk about some of the upfront stuff, yes, but then talk to you about some of the new agents on the horizon in terms of relapse refractory disease and where they sit. It's a pretty exhaustive, I should say, number of studies because we saw so much. So I apologize in advance if I have to move through this relatively fast. So let's hopefully this moves. Yeah, beautiful. So the major themes that I want to talk about, I think we've already talked with Saga's beautiful presentation this morning on monoclonal antibodies, a lot about those. So I'm actually, with your permission, going to not reduplicate that. What I'm going to focus on is in the relapse setting some very exciting data, specifically the ASPIRE trial that focused on the positive impact of the synergy between proteasome inhibition and immune modulation, where we, I think in the relapse setting, convincingly now show that 3 drugs are better than 2. Then to talk about other new agents and touch on these in broad brush, and especially to talk about small molecule inhibitors. And then to close very quickly, and in the interest of time I will move through this fast, but just to emphasize that the place of transplant remains a burning question. And in that context, we would just encourage participation in ongoing randomized trials. And in New York, it's actually great because we have a number of centers involved in the determination trial. Suzanne Lench from Columbia, Sundar Jagannath and his team at Mount Sinai, and also Hani Hassoun and his group at Memorial. So just to give you 3 centers in New York that are participating in this particular trial. Okay, so let's start. First and foremost, one of the most exciting presentations I thought of the whole meeting was presented by Keith, subsequently been published, of course, in the New England Journal, and this is the results of the ASPIRE trial. This was a randomized prospective comparison of KRD, carfilzomib lenalidomide index, compared to the control of the standard approach in relapse disease of lenalidomide and dexamethasone in this setting. And basically the background is summarized here, that we all recognize that lenalidomide and high-dose dexamethasone is a reference treatment. Obviously there are numerous other options that are available, including bortezomib-based approaches, but obviously it's a very reasonable standard arm for the control group. Carfilzomib has great promise as an irreversible, highly potent epoxy ketone proteasome inhibitor. It is quite distinct from the boronate peptide family, and in that regard, early results from trials. In fact, it's great to have Ruben here because he led the early development of carfilzomib lendex in the relapse setting and showed it to be not only well tolerated but very active. This is the design summarized here in terms of primary endpoints, secondary endpoints, key inclusion criteria, 1 to 3 priors. The exclusion, very important to note, because of the renal signal that was apparent in more advanced disease, and also the indication for lenalidomide, creatinine clearances less than 50 were not included. Patients obviously had to be image sensitive to be able to go on to the trial. There was also care to exclude patients with cardiac disease. In this context, the ASPIRE study design is summarized here. And as you can see, after cycle 18, carfilzomib was discontinued. And these were really the take-home message. There was a striking difference in progression-free survival in favor of the KRD arm. These are unprecedented results in myeloma, it has to be said. 18 months for RD, I think, pointing to the efficacy of that regimen as a PFS was much better than expected, recognizing that with the original 009 and 010 trials, our TTP was around 11 months. So this was real progress, reflecting, I think, the better tolerability of this regimen as well as our skill in managing it. Also patient selection, obviously, is a factor. But I think the really striking finding was that, once again, the combination of a proteasome inhibitor and an IMiD is synergistic clinically, and you can see a dramatic difference of over 8 months in favor of carfilzomib. To give you by backdrop, the original Garda-Ray trial, which looked at thalidomide dex versus bortezomib thalidomide dex, there'd been a 6-month improvement, but not of these kind of durations. So to see an 8-month improvement on the back of this duration was really remarkable. So strikingly positive results. Secondary endpoints are summarized here, also very positive. And the conclusions were significantly improved by over 8 months. This was really unprecedented in this context. The survival trend emerging and the overall rates of response were higher. What was also exciting is the neurotoxicity was minimal, which I think was incredibly important. Interestingly, with careful selection in terms of renal function and cardiac function, the cardiac signal was minimal, which was also good. But fascinatingly, there was a higher amount of grade 3 or more, hypertension seen with the 3 drugs. And the other interesting thing was with the 3 drugs, there was more DVT seen, which was unusual, because when we've used bortezomib in that setting, we've seen less DVT. So this was intriguing and might suggest that just as we learn more about these drugs, with carfilzomib, it may be that some of these toxicities that we've been becoming aware of may have a vascular basis. And the reason I say that is because there may be opportunities to fix that as we go forward or better understand that. And it's particularly nice that later today you'll be hearing from Javed Muslehi about cardio-oncology, and I think there'll be some interesting discussion there that helps frame it. But the takeaway message from the ASPIRE trial was excellent results, unprecedented clinical benefit, and a favorable tolerability profile with the caveats that I just made. Now, what about aprozomib? This is an oral epoxy ketone, so again, a highly potent, irreversible inhibitor of the proteasome, distinct from the boronate peptide family, very powerful preclinically. And in that context, the clinical profile was presented by Dr. Ravi Vij on behalf of a number of us who participated in this trial, including our own center. And basically, to cut to the chase here, one of the huge challenges with aprozomib has been the gut toxicity, which is a quantum difference to the gut toxicity we see with ixazomib in the same sort of patient population. Having said that, with the 2 out of 7 day schedule, we've begun to find that this is much more manageable, and with changes to the way that the aprozomib is delivered, we're seeing improvement. But we do recognize we have to give a lot of antiemetic therapy with it to make it bearable or tolerable, and that remains a challenge. But having said that, what's striking is if you look at the response rate in refractory patients, and speaking to my own patients who are part of this trial, we've had some really impressive responses in very resistant patients. So tolerability is a challenge. We're working hard to try and fix that. But at the same time, we are seeing a signal here that I think certainly warrants continued study of this particular oral agent, because I think, again, this is not, of course, a zero-sum game. We need to have more drugs, not fewer. And I'm very encouraged by the response data we're seeing from this particular experience. Now, on that note, what about ixazomib? Well, obviously, we recognize that this is very exciting. It's gone forward. It's now in upfront phase 3 trials. We've clearly established that the weekly schedule is well tolerated. We know that twice weekly can be given and is associated, certainly in the upfront setting, with very high response rates. Having said that, it's probably better tolerated on a weekly schedule, which is important. The updates from Shaji I've touched upon previously, and I will therefore, in the interest of time, be brief, but just want to re-emphasize ixazomib maintenance was presented as a viable strategy in this study, and also Shaji re-emphasized that the ixazomib Revlimid Dex platform is very potent, and again, I showed this earlier, so in the interest of time, we'll move through it very quickly. Now, my colleagues Betsy O'Donnell and Jacob Laubach, my partner, presented some very nice data on what we call RVD Lite. In the spirit of beer, we have RVD Classic, which is actually different to VRD, just so you know, because of the way the steroids are partnered with the bortezomib. But there's RVD Classic, which is twice a week. There's RVD Light, and believe it or not, there's an RVD Ultra Light. But we'll come to that a bit later. Anyway, suffice to say, for RVD Light, in the spirit of high-quality beers, it's very useful in the older population, well tolerated, and I think Jacob and Betsy were very encouraged by this, an overall response rate in an elderly population of 82%, and VGPR or better in 50%. So we're very pleased with this. This is a regimen where bortezomib is given subcutaneously weekly, lenalidomide is low-dosed at 15 milligrams, and the cycle length is 35 days. So it's been both active and well tolerated, and for an older population, seems very reasonable. Also at the meeting was some exciting stuff around the HDAC story, and I just want to move very quickly through this. We already talked about panobinostat earlier combined with RVD, and again, nice exciting results there, and with subcutaneous bortezomib, tolerability for pano was substantially improved. My point of showing this, though, is to emphasize Jatin's observation that at 4 cycles of pan-RVD, the response rate's 95%, and the VGPR at 4 cycles is 77%. So this is very interesting, actually, and the debate that we had notwithstanding, my own view on this is that this is an interesting signal, and again, informed by Saga's work with Vorinostat RVD, I'm very excited to see where this goes. And on that note, Dan Vogel from the UPenn group, in a multi-center effort that Nupa Rajay leads from MGH and that we're part of, the use of ricolinostat, which is this more selective HDAC6 inhibitor that appears to be better tolerated than the more broad PANDAC inhibitors, is very exciting. Again, Saga's involved in this study as well, and I think we're all impressed that we're seeing response rates that are quite impressive in the context of relapsed refractory disease, and the tolerability profile again seems to be encouraging, and we think the daily dosing of the drug appears to be better than the twice a day. So please watch this space, because I think the HDAC story is, with the approval of panobinostat, is going to really open as these next wave of drugs come through. Now, what about pomalidomide? Well, this is a drug very near and dear to us. It's a superb IMiD, and basically there was a lot of data on POM. Again, in the interest of time, I'm going to truncate this, but suffice to say we had data from the Stratus study in Europe, which absolutely validates on a very large scale the success of the 002 and 003 studies, the Nimbus study, which led to its approval, of course, in Europe, and the 002 trial that we led here in the United States that led to its accelerated approval. In any event, when you partner POM with various things, it does very well. There was a very nice presentation from Dr. Rashid Baz, who's a really super guy in Moffitt. Rashid did a lovely job of showing that POM cyclodex was remarkably active and associated with profound improvements in terms of disease control than perhaps might be expected in a sick population. Obviously not a huge trial, but nonetheless impressive. And then Martha Lacey presented on behalf of a number of centers, including our own, the BVD weekly bortezomib schedule with POM, recognizing that the classic PVD is twice a week. Well, very interestingly, in this selected population, and I think patient selection plays a role in this, she showed really an amazing result, 85% response rate. This is POM given 3 weeks on, 1 week off, and bortezomib given weekly. So to see in a relapse refractory population, because remember, these patients actually all had to be refractory to LEN to enter the trial, so they are actually they are relapsed and refractory, although not all double refractory. And in that context, to see an 85% response rate and a PFS approaching 11 months is quite remarkable. So we are very pleased with this. The bortezomib in this study is given twice a week. I should mention that the current study ongoing with bortezomib and pomalidomide is the Optimism Trial. And for those of you who are close to centers that are participating, would welcome referrals. These are for relapsed patients in whom bortezomib-based therapy is a rational approach to which they have access then to open-label POM as part of that trial. So I'm going to change gear a little bit and just talk to you very briefly about other new drugs. Cytotoxics have seen a little bit of a rebirth. There's this exciting molecule called melflufen, which actually appears to be melphalan without the baggage, to cut to the chase. And in that context, our colleague Claudia Pablo Prada presented a very nice poster presentation showing that melflufen does appear to be active and well tolerated in this group. Dr. Antonio Palombo is part of this trial, and in the phase 2 part of the study, he in particular and his center are enrolling very aggressively to the trial, and we're seeing very interesting results. He obviously is an expert with melphalan and is impressed that melflufen may be a real step forward. And we're at fixed dose of 40 milligrams, and it's once every 3 weeks, and it appears to be performing very well with dexamethasone. So similarly, if one looks at other cytotoxics, Irene Gabriel and my partner Jacob have led a study of TH302, which is this threshold compound which is activated in the context of an anaerobic microenvironment. So if it's hypoxic, basically these hypoxic conditions generate activation of the prodrug to a highly active DNA alkylator that's actually a bromoisophosphoramide. And I say that simply because it's a very selectively activated drug. What's really interesting is when you combine it with bortezomib, we saw really nice results. So this is a very interesting compound. It's shown great promise in other solid tumor settings. Now I'll move on to some really exciting data with other combinations. Carfilzomib Pano is under study. Jonathan has led this with Saga's leadership. And what's been shown is this is feasible and it's highly active. One word of caution, there was one grade 5 cardiac event in the trial. Having said that, it's otherwise been generally very well tolerated. And what's been impressive is these high rates of response. Weekly carfilzomib has been explored by the Italian group. This is important, obviously, because it will enhance patient convenience, particularly for older patients. So this was a newly diagnosed myeloma. We touched on this earlier. But suffice to say, very nice response rates and encouragingly a safety and tolerability profile in an older patient population that's also quite good. So going on, there's now very nice work that Saga presented on the array compound, the 520. And this study basically builds upon the concept that this spindle inhibitor actually has remarkable activity preclinically as a monoclonal spindle arrest and apoptosis resulting from its exposure. And in that context, this study looked at the combination first with dexamethasone and then as a single agent. And again, I think it's fair to say, and Saga can speak to this much more directly, there's been some encouraging early signals from this compound. Now, when you then go one step further and combine it with carfilzomib, as Jatin and Bob's group have done, you see some very interesting results as well. Again, I'm sorry, I'm moving a little too fast. Apologize. Oops, am I going backwards? One back, please. Yeah, here we go. Basically, remarkable results in bortezomib refractory patients with this combination. So watch this space for the array compound. It does seem very interesting. Okay, now we'll go into more of the world of small molecule inhibitors in the more classical sense with this pan-PIN and kinase inhibitor, LGH447. This is a collaboration with Novartis. It's a multi-center study in which Shaji Kumar at Mayo is the senior investigator and Mark Raab from Heidelberg in Germany is leading. And in the context of this molecule, there's a strong preclinical rationale to its use. I'm summarized here in these preclinical murine models. And then the study design was a classical dose escalation of the molecule. And on that context, basically the MTD has been established at 500 milligrams once daily. There's been hematologic toxicities, but they've been generally manageable. And this is very interesting. There has been a response signal, which for a single agent is intriguing and certainly warrants further study. So that's going forward. Now, I do want to talk in the same vein on ibrutinib. This is the BTK inhibitor, which obviously has had such success in other B-cell malignancies. And what we've seen here is based upon some important preclinical work that does suggest activity, that as a single agent or in combination with dexamethasone, in a fairly large study, in fact, we've been able to demonstrate a signal. There is a response rate here. And again, it's very intriguing because it sort of points to the fact that this may be a very exciting combinatorial agent going forward. Finally, just want to talk about selinexor, which again is a fascinating new approach. And basically, this is the use of these SINE inhibitors, which may be very important going forward. This is selinexor plus dexamethasone. This study was led as part of also the MMRC. And I'm sorry, I just want to show you here that basically the response rates were encouraging in a very small number of patients, but nonetheless intriguing. And while some of the side effect profiles have been challenging, we're very hopeful that this particular drug going forward may have real promise. So, again, a very exciting new mechanism. The last couple of minutes I want to close by just talking a little bit more about where transplant belongs. This was obviously a session that we presented at an educational discussion of the meeting. And the point simply was, with the European data showing benefit to early transplant, does that necessarily mean that obviously the question is answered? We would say absolutely not, because of course this particular trial just looked at lenalidomide and dexamethasone alone as an induction strategy. One very important message from Antonio's study, though, was that lenalidomide maintenance until progression clearly resulted in benefit. So that was a very important part of this trial, which of course remains to be properly dissected and discussed and analyzed in forward studies. So I've already touched on all of this, but there was one takeaway message here that I wanted to mention, which is that when you look across trials and you think about studies between countries, always remember this analysis. This was from John Careth back in 2007, but what he shows is that actually the impact of salvage impacts upon whether or not early versus late transplant matters. And one of the reasons in the US we may have this question in a different way than our European partners is that in Europe, not only are their healthcare systems much more driven by one size fits all for economic reasons, but also their access to salvage strategies is different. Therefore, the impact of early versus late, extrapolating from the European experience, does not mean it applies to the United States, because we're blessed with access to excellent salvage options, and in that context, overall outcomes may be different. So that was an important takeaway from the educational session at ASH, pointing to the fact that, again, in the US, it begs us to conduct large trials comparable to our European partners, because to simply extrapolate from European experience to our own may actually not do justice to our patients. Okay, so on that note, I just wanted to close and thank you very much for your attention. My effort was to try and get us back on time, and Simon's waving, so I think we have achieved that. And I would like to thank you very much for your kind attention, and now hand over to Saga and Ruben. Thank you.